previous video we were discussing about extended release preparations, right? And we discussed that they have a prolonged duration of action as compared to normal drugs, okay? Their duration of action actually increases, right, whenever we use an extended release preparation. Okay, and why is this used? What is the practical example in which this is used? This is basically used for morphine. You need to remember this drug, that it is used for morphine. Why? Because the half-life of morphine is 2 to 4 hours. What is the half-life of a drug? It means the time taken in order to make the quantity of this drug like literally half, okay? So this drug is being, metabolized to half of its level. For example, if I have 2 kg, वैसे this is not a practical example. So I will take half of 2 kg. That will be 1 kg will be eliminated. Eliminated in how much time? In this much time, 2 to 4 hours, okay? So this is the half-life of morphine, right? So morphine has a very short half-life, and if we keep on giving the drug on this half-life, so we'll have to give it like 6 to 8 times in a day, which is not practical at all, right? So what do we do? That we give the extended release preparation of morphine. In this time, what happens is that only 2 doses need to be given. Why? Because the extended release version has a greater half-life, and hence the drug is being eliminated less, okay? It is being metabolized less as compared to the normal mechanism. So I hope you got the concept of the extended release preparations. Now we move on to the next one, which is sublingual or buccal administration, okay? Now what do you mean by sublingual? Sub means below, and lingual refers to the tongue. So this means below the tongue. What do? We place the drug below the tongue, and it involves the placement of the drug between the cheek and the gum. Either the drug is placed below the tongue, or it is placed between the cheek and the gum. Why? Because they are rapidly absorbed. What are the advantages? They are rapidly absorbed. And why is that? Because our mouth contains very small, very minute capillaries. So this allows for diffusion, and this really helps in the exchange of materials, right? So these materials, these drugs are being, absorbed very quickly. And the next is bypass of the harsh gastrointestinal movement. If we take the drug orally, it has to pass through the whole, whole stomach, small intestine, large intestine, liver, etc., etc. It has to pass through the whole GIT tract, right? But over here, when we take the drug by buccal, what happens is that the capillaries which are directly present below the tongue or in the cheek, they will directly absorb the drug, and this will go into the circulation directly. So it will avoid the GIT tract, it will avoid the harsh gastrointestinal movements of the GIT tract, and also it will avoid the first pass metabolism, which we just discussed. That what is it? When the drug has to pass to the liver, first through the hepatic portal vein, after absorption through the stomach. What happens is that whenever the drug is being absorbed into the stomach, then it has to go to the liver, and then it is metabolized, and then it has to pass through this hepatic portal vein, and then it can go somewhere else. So there are so many steps involving the oral route. So instead we adopt the sublingual or the buccal route, because drugs are being rapidly absorbed by this. Alright? So we have discussed this page successfully, this whole page. We are done with this. Now we move on to the parenteral routes. What is the meaning of parenteral? Par means to bypass, and enteral means to basically the GIT tract. So we are indirectly bypassing the GIT tract, and we are directly transferring the drug into the systemic circulation. It is the mechanism by which we directly put the drug into the blood. Okay, for example, what are the types of this? We have intravenous, IV, then we have intramuscular, IM, then we have subcutaneous, SC, and then we have intradermal. Okay, so first let us understand the angles at which we have to place the injection when administering all of these routes, and then we're going to read from the book as well. So our skin has different layers. Okay, let's draw them. The first one, this is the epidermis. Then this one is the dermis. Then we have the hypodermis. I hope you all can see. Yes. And this one, the last one, is the muscle. So what happens is that intramuscular injection is always administered at 90 degrees Celsius. See, like this. It goes directly into the muscle, and at what level? What's the angle? 90 degrees. Intramuscular. Next we have subcutaneous. Subcutaneous goes till this layer and at the angle of 45 degrees. This is subcutaneous. Next we have intravenous. Intravenous also goes into, it basically goes into the vein, right? The vein which lies over here. Now it's going into the vein, but the angle is 25 degrees Celsius. Sorry, not Celsius. It's not Celsius, okay? This is intravenous. And the last one we have is intradermal, which goes into this one, into the epidermal layer. Okay, epidermal and the dermal layer. And then like this, it's just like this, and the angle which is being formed is 15 degrees. Okay, so this is what this is, intradermal, right? So these are the four major routes of administration of parenteral drugs. Okay, and these directly transport the drugs into where? Into the systemic circulation. Now when do we use parenteral drugs? Because they are very scary to some people, right? People have phobia of injection, people have phobia, children especially, they have phobia. So why use them when we have oral drugs? So the problem is that some of these drugs are poorly absorbed in the GIT tract. For example, heparin. Your book contains this example that heparin is poorly absorbed into the GIT tract. That is why it is directly referred as a parenteral route. And also, some of these are unstable. For example, insulin. Insulin is unstable when it is given into the GIT tract. That is why it is also referred to the parenteral route. Alright. Now, here are some disadvantages. This route of administration is irreversible. It causes pain, fear, local tissue damage and infections. If it is not administered properly, what it causes, it injures you basically, right? So it causes tissue damage and infections. The four major parenteral routes are intravascular, venous or arterial, intramuscular, subcutaneous and intradermal. So IV contains two of them. Intravascular contains intravenous or intra-arterial. Right? IV injection, it is the most common of the parenteral route. It is useful for drugs that are not absorbed orally. For example, the neuromuscular blocker, that is ruconium. Okay, so this is what? This is a neuromuscular blocker and it helps in intravenous administration. IV delivery permits a rapid effect and a maximum degree of control over the amount of drug delivered. So the advantage is that, you can write the advantages. IV has a rapid absorption rate. Okay, and it has a maximum degree of control over the amount of drug delivered, right? When the injection has when injected as a bolus, the full amount of drug is delivered to the systemic circulation almost immediately. What happens is that we have two kinds of IV, either as a bolus, which is being given in a single shot, right? or we have intravenous infusion, the drip. Have you seen the drip, right? IV infusion. The drug is infused over a longer period, resulting in lower peak plasma concentration and an increased duration of the circulating drug. Okay, so what happens is that either I give IV as a bolus or I give IV as an infusion. What happens in an infusion, it is more time taking. Bolus is less time taking. This is more time taking. And what happens in a bolus is that the bolus is it increases plasma concentration rapidly for whatever we inject. And this infusion, it does not increase it to such a height, but it keeps on slowly and gradually increasing. Okay, it is given over a longer period. Next we move on to intramuscular. Drugs administered intramuscularly can be in aqueous solutions, which are absorbed rapidly, or in specialized depot preparations, which are absorbed slowly. So there are two kinds over here as well. One of them are absorbed rapidly, okay, which are aqueous solutions, and the depot preparations, they are absorbed slowly. And the depot consists of a suspension of a drug in a non-alcoholic vehicle, non-aqueous vehicle such as polyethylene glycol. So intramuscular, let's divide it like this. Intramuscular, first we have aqueous, next we have depot. Okay, and in a depot preparation we have what? We have a suspension. We don't have an aqueous solution, we have a suspension, and the chemical which is used in polyethylene glycol. Right, now this vehicle, as the vehicle diffuses out of the muscle, the drug precipitates at the site of injection. The drug then dissolves slowly, providing a sustained dose over an extended interval. Okay, so what happens to this drug is that it stays inside the muscle, and then it keeps on slowly and gradually it dissolves. Okay, see, look at this graph. This is 5 milligram of intramuscular drug, and this is 5 milligram of intravenous drug. You see that the height of the plasma concentration that is reached when the drug is given intravenously. Why? Because it is being rapidly acting, right? It is absorbed rapidly into the body when it is intravenous. And when it is intramuscular, what happens is that it first comes in a vehicle, either it is aqueous or it comes in a vehicle that is basically a suspension or a depot, and it is made up of polyethylene glycol. Now when this polyethylene glycol, this is our muscle, this is the muscle, polyethylene glycol leaves the muscle, so it keeps the drug over here. The drug still stays inside the muscle, and when this drug stays inside the muscle, so it slowly and gradually it is being absorbed into the body. So that is why there is no great peak. As this peak is very great, there is no peak over here in intramuscular. Okay, I hope you got the point, and I hope you guys can see everything. Actually, I'm not that pro in recording videos. I've just started. So anyways, let's move on to the next, that is subcutaneous. Now what is subcutaneous? We are basically this thing is the subcutaneous layer inside the subcutaneous tissue, and it is given at the angle of 45 degrees, as you can see over here. Like intramuscular, subcutaneous also provides absorption via simple diffusion, and it is slower than the IV route. The IV route is the fastest, okay, and it is the most common. And subcutaneous is slower and it absorbs via simple diffusion. Subcutaneous injection minimizes the risks of hemolysis or thrombosis which are associated with IV injection. So whenever this is an advantage of subcutaneous injection, that although kids are also scared of this, but it does not lead to venous or arterial damage if the injection is not being administered properly. So it can lead to hemolysis, right, in intravenous administration, but in subcutaneous it does not lead to this thing. It may provide slow, constant and sustained effects. This route should not have been used with the drugs that cause tissue irritation, because severe pain and necrosis may occur. Okay? So what happens is that when it is used with the drugs that cause tissue irritation, so subcutaneous basically means the transfer of the drug into the tissue, right, into the subcutaneous tissue. Now if certain drugs are given that already irritate the tissue, So it will cause a lot of pain to the patient and it will cause necrosis of these tissues. So we don't want that, right? So this is a rule of administration of subcutaneous that you have to learn. Next we have intradermal. Intradermal involves injection into the dermis, the more vascular layer of the skin under the epidermis. So this is the epidermis and this is the dermis. So this injection is being given at the degree of 15 degrees. Okay. Agents for diagnostic determination and desensitization are usually administered by this route. Okay, so this is not that important. Let's move on to the other routes. Okay, so this table is a very nicely written table which you can easily follow, and if you only learn this table, still then you will clear and ace your pharma, because this has all the advantages, disadvantages and examples. So you won't need to read the text again and again, but if you read it once with my video, it will be fine. And for your exam point of view, you guys can go through the tables of lippincott. Okay, tables and the pictures. Now we move on to the other routes of drug administration. Oral inhalation and nasal preparation. So what happens in oral inhalation? They provide a rapid delivery of the drug across the large surface area of the mucous membranes of the respiratory tract and the pulmonary epithelium. So the respiratory tract, it has a very large surface area. Why? Because due to the presence of a highly extensive, respiratory system that contains alveoli, that contains mucous membranes, right? So mucus and everything, they are very absorptive. So they absorb whatever is being given to them. Hence, drugs are also being easily absorbed. Drug effect are almost as rapid as those with the IV bolus. So the concentration peaks over here. In oral inhalation, the concentration peaks. Why? Due to the presence of the respiratory tract, right? Drugs that are gases, for example anesthetics, and those that can be dispersed in an aerosol are administered via inhalation. So the patient is asked to inhale the drug, right? For example, when anesthesia is given, it is also being inhaled and then the patient falls asleep, right? So it is given via this route, via inhalation. This route is effective and convenient for patients with respiratory disorders such as asthma or chronic obstructive pulmonary disease, because drug is delivered directly to the site of action. Okay, so it delivers, this point should be very clear, that the drug is delivered to the site of action and it avoids respiratory disorders, for example COPD, which is chronic obstructive pulmonary disease. Okay, the nasal route involves topical administration of drugs directly into the nose, and it is used for patients with allergic rhinitis. Mark this point, this is very important for your MCQs, that why is the nasal route used. So you have to tell that it is used for allergic rhinitis, or you can also write this point over here in inhalation, that anesthesia, you can write points like anesthesia, you can write points like chronic obstructive pulmonary disease, people with COPD or people with allergic rhinitis are given the drugs directly through their nose. And also you need to learn all these examples. Okay, so then it's good for your MCQs, especially this example, nitroglycerine, which is being given via the sublingual route. Okay, so this is a highly important example. And this one, hydrocortisone cream, which is given via topical route, learn this one as well. And this one as well, insulin, which is very important, and it is given through the subcutaneous route. Alright, next we move on to the intrathecal and intraventricular. So what happens in this is that when we have to give the fluid, when we have to give the drug directly into the CSF, that is the cerebrospinal fluid. Now what is the obstruction? The obstruction is basically the blood-brain barrier, which prevents the absorption of drugs into the CNS, right? So whenever we need rapid effect, we need to transfer a drug rapidly into the CSF, what we do is that we introduce an intrathecal or an intraventricular administration of the drug. Next we have topical. What is topical? It basically means on the skin, over the skin, right? Topical is used when a local effect of the drug is desired. Next we have transdermal. The route of administration achieves systemic effects by application of the drugs to the skin. What happens is that these drugs are given to the skin via a transdermal patch, and the rate of absorption can vary. It determines on the physical characteristics of the skin at the site of application. Okay, It depends upon how the skin looks like, whether it has cuts or marks or whatever, and it also depends whether the lipids are soluble in this transdermal patch or not. Okay, whether the lipids are the drug, basically if it is lipid soluble, then only it can be used as a transdermal patch. If it is not lipid soluble, then it cannot be used. Next we have rectal. Why are rectal drugs used? Because if the taste of the oral drug is very bad and the patient is not able to eat it, or the patient would vomit, right? If the drug causes vomiting, or if the patient is in a coma, how do we give a drug orally? So then we give the we give the drug rectally. Okay, and what happens is that this partially bypasses the first pass effect. This can come as your MCQs, that it does not completely bypass the first pass effect, it partially does it. Why? Because it still enters the GIT tract. 50% of the drainage of the rectal region bypasses the portal circulation. Okay, it bypasses the whole circulation. The biotransformation of drugs by the liver is minimized with rectal administration. Okay, this route is useful when the drug induces vomiting. We have already discussed that. And it is incomplete, erratic and incomplete, and it irritates the rectal mucosa. So whenever a drug is given rectally, it is not a very well accepted route due to social concerns as well, and it also irritates the mucosa which is present on the rectal surface. Next we have absorption of the drugs. How are drugs absorbed into our body? First we discuss the routes of administration by which the drug is being transported into our body, right? Now we have to discuss how the drug is being absorbed into the body. We are going to discuss this in the next video. So make sure that you guys watch the next video as well. Till then, take care. Allah Hafiz.